So I welcome you all on behalf of New Delhi Healthcare Academy. We are into healthcare teaching since 2010, and today we are beginning with our first class on basics, that is the ultrasound imaging of normal gynecology anatomy for 1 hour. After that, we are going to talk on ultrasound imaging of normal gallbladder and cholelithiasis. There are a lot of participants who are already enrolled with us and have already attended our class on physics. And maybe for them, this is second class, but those who are attaching with us or maybe listening to us for the first time will have an understanding that how we go in-depth teaching on a particular subject. And today we are going to teach on ultrasound anatomy of normal gynecology. Okay, now let us see this. So I've kept this slide deliberately in the beginning because I want to tell myself and to all our doctor friends who are joined with us today that we must go back to our basics. So if you look at this diagram, this all of us have learned during our MBBS time that how a normal uterus looks like. So if you look into this, this is the fundus, this is the body of the uterus, and that is the area of isthmus. And then here comes the area of the cervix. Okay, here is the ovarian ligament through which that ovary is being attached. These are the two fallopian tubes, and fallopian tubes normally, if they are not dilated and if there is no fluid in the surrounding, we are not able to see them on the ultrasound. And now one by one, we'll go ahead with how we see these structures on trans-abdominal scan as well as trans-vaginal scan. So if you look into these two pictures, maybe in the beginning, you will not understand that what we are able to see, but definitely at the end of class, you will say, yes, we all are at the same level of understanding. So now today, what all we are going to talk about, importance of history taking. Now in gynecology, it's very important to know the age of the patient because those who are in the reproductive age group, they will have a different kind of an endometrial thickness throughout their menstrual cycle, and maybe ovaries will also show you different follicles or the cyst or maybe corpus luteum as per their menstrual cycle. We also have to look into their main complaints. Why have they come to us? Is there any history of any surgery? Let's say if they've already undergone hysterectomy and we are looking for uterus, that means we are basically wasting our time. Then, of course, the most important thing is what equipment we have to use. Do we need to do a trans-abdominal scan or directly we can go ahead with trans-vaginal? Do we require a full bladder or not? What is the probe orientation? Very important. Patient positioning, where we are going to sit. How to insert a transvaginal probe in case we are doing a transvaginal scan. Image optimization, extremely important to understand where is right, left, superior and inferior on the image. And then how to have the systematic scans with the scale pictures as well as the videos. We are going to touch base on the grayscale and also on a little bit of color Doppler and ultimately the report writing. Now the methodology, very important is what all we are going to do. The trans-abdominal scan basically is a transducer with mid to low level frequency. That means between 3.5 to 5 megahertz. Transvaginal is a high frequency probe, 7 to 10 megahertz frequency with a very high resolution, but with a low depth. Then we take B mode as well as cine loops in order to see the recorded still picture as well as the videos. For color Doppler and power Doppler, remember this, the setting is very important. So those who haven't attended our physics class or thinking of joining us, they must understand that nobology is a very important class before we actually start doing an ultrasound. So for color Doppler usage in gynecology, we need to keep PRF very low, about zero point 0.3, which shows or catches the velocity range of the vessels in 5 to 10 centimeters per second. Then we need to keep wall filter also at the lowest, and Doppler gain artifact, Doppler gain just below the artifact level. So this all, of course, we're not going to talk in detail because of the fact that this has already been discussed. Now let us understand what are the common indications. Why do you want to do a pelvic ultrasound? So if you're looking for an ultrasound evaluation for a pelvic pain, any pelvic masses, any endocrine abnormalities like polycystic ovaries, dysmenorrhea, amenorrhea, any abnormal bleeding, delayed menstruation, or previously detected abnormality, and you want to recheck what are the advantages of the medicine being given, then monitoring of the patients as well as diagnosis of the infertility patients, and many more like pelvic infection and localization of an IUCD, or maybe an evaluation of congenital uterine anomalies. So these are the indications which we all are familiar with. But since today's class is more on ultrasound, so we are going to discuss more on that. Now, what are the pre-requirements? What should we do before we begin with an ultrasound? We should try to explain the procedure to the patient. In fact, different societies, ultrasound societies in Europe as well as in USA, they say that we should go for a written consent before we in fact go for transabdominal or transvaginal ultrasound. And then we should also have an attendant standing along with us in case we are planning to do a transvaginal ultrasound, in case the scanner or sonographer or sonologist is a male doctor. Then we should understand that which probe we have to use, convex or endovaginal, where the full bladder or empty bladder is required. After taking the clinical history in detail, that exactly why the patient has been referred to us, you must also take the history of any previous medication. In case the patient is on tamoxifen or any other medication, like maybe just an oral contraceptive pills, then maybe an endometrial thickness or the ovarian volume or the ovaries will look differently. So history is extremely important. And again, we'll be emphasizing that please do not start doing an ultrasound without properly taking history. Now, this is a very important slide in which we are talking about this fact that what all we have to see. We have to understand the normal anatomy and its variance as per the age and the menstrual status of the patient in two different planes. We must assess the size of the organ, that is the uterus or maybe the endometrium or the ovary, orientation, because we'll be talking later that is the uterus anteverted or retroverted, retroflexed, or this is known as orientation, and we must have a clear understanding of that. Then ecotexture. How does the ecotexture of that particular part, like an endometrium or myometrium, is looking like? Shape, outline, very important. Because once you know the normal anatomy, and if you are seeing a large myoma arising out of myometrium, if you know the normal shape or the outline, you will definitely not miss that myoma while scanning. And then, of course, the mobility, which we can test on our transvaginal probe, because transvaginal probe, in fact, is nothing but an extension for a bimanual examination by a gynecologist. So at present, today's need is that all the gynecologists should be well versed with doing an ultrasound, especially for their own patients. Now, what all we have to look into? We have to, while doing a transabdominal or maybe transvaginal, we must see where the bladder is. Try to look into its size, shape, and the contents. Cervix, the internal loss, the external loss, the cervical length, and of course, its outline and ecotexture. Vaginal assessment is outline and ecotexture, and the pouch of Douglas, presence of any fluid, the amount of fluid, or any other abnormality or pathology which is being seen there. In uterus, important thing is to look into its position. Is this anteverted, retroversion, anteflexion, retroflexion? Everything we'll be discussing in detail in next few slides. Of course, is size depending upon whether she is in reproductive age group or postmenopausal. Then endometrium, very important because the endometrium measurement varies between 2 to 14 millimeters depending upon which part of age group she is or which part of menstrual cycle she is at present. Then in myometrium, looking into his ecotexture, presence of any hyperechoic or hypoechoic areas, which could be either the myomas or the adenomyosis. In ovaries, very important to look at their position, their shape, size, volume, echogenicity, and antral count. Because anywhere, whenever we are doing a gynae ultrasound, we need to have a clear understanding about the antral count. Antral count is nothing but counting the number of follicles which you see during the first 4 to 5 days of a cycle. Then in adnexa, which we have clearly understood that fallopian tubes, normally fallopian tubes or normal fallopian tubes are not visible unless they are either diseased or there is a fluid in the surrounding. Now, how should we begin? We should actually always begin with a TAS, that is trans abdominal ultrasound. And when you're using a trans abdominal ultrasound, for that we use a curvilinear or a convex probe, which I told you is a mid to low level frequency, but has a good depth. So when you're keeping this on the abdomen or in the pelvic area, remember this, we need to have full bladder so that acts as an acoustic window through which we can see the uterus and the adnexa. So full bladder is must for a transabdominal ultrasound. And this is how a transabdominal, or you can see a convex probe, looks like. Very important thing is to look for a marker here, marker. And we'll be now understanding that how we are going to use this transabdominal scan and what are the basic rules of scanning. So remember this, that whenever you're looking at this probe, okay, so this is how, this is, you can say a probe when you're keeping that transversely. So what we have to understand is orientation of the image. So correct holding of the transducer and the orientation of the image is must. The transducer should be held in a transverse position in such a way that fingertip, when touched on one side of transducer, should produce an image on the same side of the monitor or the screen. This transverse position helps in identifying right and left aspect of the image. So when probe is held in correct orientation, the right side of the screen corresponds to right side of the patient. See now, very beautifully, you all can see that this is how you're going to hold the transducer in your hand. There is a marker here in all the transducers, but why I'm not emphasizing only on the marker, because there is an invert button which is present, and if you press that, then the inverter, the importance of that inverter changes. So what we should ideally do is try to put the finger on the right side when you're holding it correctly. So this right side of the probe and the right side here on the screen should match. So when you're holding the probe transversely in this manner correctly, then you will see that this is the right ovary and this is the left ovary. That means when you're looking at the monitor, right side of the monitor is showing us the right ovary, left side of the monitor is showing us the left ovary. Okay, and this is the uterus in between, the transverse section of the uterus in between. This is the full bladder, which is acting as an acoustic window through which we are able to see this hypoechoic organ, which is nothing but a uterus. On one side, we are seeing one ovary. On the other side, we are seeing another ovary. And in this, we are, when you're holding the probe transversely correctly, then you will see that right side appears on the right side of the monitor, for the right side of the patient appears on the right side of the monitor. Now, how to bring the image for the longitudinal section of the uterus? So you've got two options. One option is when you turn the probe either from right side up or the left side up. So what we have to do is that we have to turn the probe in such a manner that right side goes up. When the probe is moving longitudinally, the probe should be turned in such a manner that right side becomes superior. So when the probe is aligned longitudinally in correct position, the image gives us the information about the superior and inferior dimensions of a particular organ. In correct alignment, the right side of the screen corresponds to the superior aspect of the patient lying in the supine position. So that means anything on the right side of the screen is superior and anything on the left side of the screen is posterior. Now let us see this. You have turned your probe in such a manner that now this from right side, we have turned it towards the superior side. So when you're holding the probe correctly, that time, as I told you, this right side of the screen becomes superior and the left side of the screen becomes inferior. So while looking into the longitudinal section of the uterus, we all know the fundus is superior in the body. The cervix is below and vagina is the lowest most portion of this organ. So if there is a correct orientation or if you're holding the probe correctly, then you will see that this fundus will be seen on the right side of the monitor and the vagina will be seen on the left side of the monitor. So this orientation is very important, whether we are working in India or any foreign country. This orientation remains same for all the countries. That means we have to follow this system of right, left, superior and inferior. Again, just to repeat, when you're keeping it transversely, there's a marker here that when you press on that, the right side is on right side, left over here. You have turned from right going up. So this is how now probe is pointing. So that time the right side of the screen is telling us the superior portion of the body of the organ we are imaging, and this is the inferior portion of the organ. So remember this. This is important orientation for TAS scanning. And now we'll be looking into the uterus with different zones of echogenicity, the myometrium, endometrium, and again, we'll go ahead. Now, in this picture, we will have a clear understanding that on trans-abdominal scan, when we are keeping the probe longitudinally, this is how you see that this is the longitudinal section of the urinary bladder. Urinary bladder contains urine or anywhere in the body where there is a water that looks black or anechoic in color. And what is this? This is the body of the uterus. This is the body, the anterior wall of the uterus. This is the fundus. This is the posterior wall of the uterus. This area is the pouch of Douglas. This is the area of the cervix. This is the vagina. This is the vaginal mucosa. And if you're holding the probe correctly, we can see that right side is showing us the fundus and left side is showing us the vagina. In the transverse section, we see the transverse section of the uterus, and in this we see right and left ovaries. Okay, and one by one then we'll look into the echogenicities of different parts of the endometrium and the myometrium. But for the sake of understanding, the serosa looks white in color. This myometrium looks hypoechoic in comparison to this white hyperechoic serosa. This is the innermost layer of the myometrium, which is little darker in color. Then comes the endometrium, which is white in color. And here is the area of the cervix, which we'll be discussing, that how to identify cervix, which is very, very important. And this is the vaginal mucosa, which also looks white in color. Again, see this picture, trans-abdominally, we can see here, this is the vagina, which is coming. And there are two angles which are coming here, which is the angle of version and angle of flexion, which we'll be discussing in detail in coming few slides, and also understand that how the measurements of the uterus are taken. Now, let us see this video to understand something. This is a trans-abdominal scan. And as you all are seeing that we are using the zoom also to see that now see, we have turned our probe from transverse to longitudinal section. And beautifully, we can see the longitudinal section of the uterus coming into view. And nicely, we can see that if you're holding the probe correctly, Right side of the screen is showing us the fundus, and the left side of the screen is showing us the vagina. That means we are holding the probe correctly. So when you start seeing this transabdominally, this is the transverse section when you're holding the probe transversely. And the moment you turn the probe in the longitudinal section, if you're holding it correctly, this is how you're going to see the fundus and the vagina coming into view. So this is the orientation of the uterus in transverse and the longitudinal section, which is extremely important. And we all should know how to do this. Now we will move ahead towards the transvaginal scan, because remember this, unless there are some large myomas or any ovarian cysts which are so large enough that we are not able to do a transvaginal ultrasound to take their exact measurements, we actually are required to learn transvaginal scan for all gynae purposes. So all those sonologists and or maybe the gynecologists who are there with us today should know that transvaginal scan is something that we all should learn, that how to use of that and how to do the interpretation of the normal anatomy in the transvaginal scan. Now, what are the advantages? This is a high frequency transducer. As I told you in the beginning, this ranges between about 7 to 12 megahertz. Definitely, it has got a very good resolution. But then depth is a problem. That means only 7 to 8 centimeters of the depth we can see. Then it is useful for those patients who are not able to fill their bladder, in obese patient where too much of fat is there and we are not able to see well, in retroverted retroflex uterus. Sometimes when you're doing a transabdominal scan and you feel that, oh, it looks like a myoma, but actually that's a retroverted or retroflex uterus. So that's a very helpful technique that we must do a transvaginal scan. Then for better characterization of the internal characteristics, very important for the ovarian masses. Is it a malignant mass or a benign mass? So that helps in transvaginal scan is very, very important. To distinguish between a mass and an ovarian loops, very, very important. Better characterization of the endometrium. And then, of course, the most important thing is that if case male sonologist is doing an ultrasound, then we must have an attendant along with us. Now see this, how a transvaginal probe looks like. So this is a long handle and this part is known as the footnote. So this is the area from which the ultrasound beam is going to come out. So you can see this narrow handle actually enters inside the vagina. Now see this picture again, how the doctor is holding this, and see this is entering inside the vagina and reaching till the cervix. That means now you can understand how close we are to the uterus and to the ovaries and maybe also to the urinary bladder and the pouch of Douglas. So first importance is you're very close to the area of interest. Second, you can also do a mobility check. That means if you are a little susceptible about the fact that if there are any, you can say endometrial patches in uterosacral area and you are not able to find them on, let's say, on routine ultrasound, then this touching of probe here, in case it is eliciting pain, or in case there is a pyosalpinx or any other ectopic pregnancy, then this transvaginal probe is very important to elicit the mobility as well as to check the sliding sign, also to look for any pain in this area. So how should we actually begin with doing a transvaginal scan? So in transvaginal scan, there is a marker here. As I told you in the beginning, that there is a marker on the transabdominal scan also, but on that we do a finger test. But in this, there is a marker here, and you have to keep this marker at 12 o'clock position. That means if you look at the clock right above. So how see now? This doctor is holding this probe, the marker is here, and this is a mannequin, and this is how you will be entering the probe inside the vagina after applying the jelly and the probe cover over this. So how you're keeping this marker right at 12 o'clock position. So this is very, very important to understand how to hold the probe. So when you will be inserting the probe in this position, you will start seeing the mid-sagittal portion of the uterus. I will show you how. See, we are inserting the probe inside. This marker at 12 o'clock position. So as I told you, when we'll be inserting this, you will see the sagittal section of the uterus. I will show you how. And then for seeing the transverse section, we have to rotate the probe anti-clockwise. We have to rotate the probe anti-clockwise. This is what is the learning in this transvaginal probe insertion and then rotation. So remember this by heart, that in case you're already doing a transvaginal scan or you are a beginner, you must identify this probe marker, put it on the 12 o'clock position, insert this inside the vagina to look into the mid-cell section. And when you want to see the transverse section, rotate the probe anti-clockwise. Rotate the probe anti-clockwise to look into the transverse section of the uterus. Again, see this. This is how, let's say, a patient is lying down. So this is the vagina where we are going to insert our transvaginal probe. This is the area of the cervix, and here the uterus starts. Okay, this we all understand very beautifully. Now, what are you seeing here? Bladder is seen superiorly, right? And the rectum is seen posteriorly. Same here. Now see this. When you are inserting this with a probe, with the marker above at 12 o'clock position, you will see the mid-sagittal section of the uterus. Okay, this is how the mid-sagittal section of the uterus, same as this. Okay, see this picture, and you will have a clear understanding. This is the endometrium, and this where we are not showing you is the urinary bladder. Always you have to keep the urinary bladder on this side. If you're holding the probe incorrectly, then you will see the urinary bladder coming on that side. So we don't have to do that. Only sometimes in retroverted, retroflex uterus, where you're not able to identify the uterus well, that we have to change this orientation and maybe also write in a report that we have changed this orientation. But if the patient is lying in a supine position in this manner, and you are inserting the probe in this manner, as I told you, with the marker or 12 o'clock position, you will see the mid-sagittal section, or which is also known as the longitudinal section of the uterus, in this manner. Okay. And then, as I told you, we'll turn the probe anti-clockwise to see the transverse section of the uterus, and the right will come on the right side of the screen and left will come on the left side of the screen, as we have already seen in the trans-abdominal scan. As we have already seen in the trans-abdominal scan. Hope this part is clear, because if you haven't understood how to insert the probe and how to orient the image in transvaginal scan, then the further learning is going to be difficult. So today, once this class is over and you go back to your home, please do look into this picture and familiarize yourself that how to insert the transvaginal probe. See now again, can you see this? This is the foot mark of the transvaginal probe. Here you can see the marker which is coming on this side. As I told you, bladder on the right side of the screen. This is the area of the cervix. Okay. And when you are inserting the probe in such a manner that this is the anterior wall of the uterus, this is the fundus, this is the posterior wall of the uterus, this is the thin endometrium, because while we were doing this scanning, she was in the menstrual phase. This is the area of the cervix. We'll discuss later how to identify cervix, and this is the cul-de-sac. So now we all are 100% sure how to hold the probe for transvaginal scanning. Now let us understand how to identify different structures by using zoom. So zoom is something very important to identify. Now see, this is the cervical canal first, then comes the endometrium. Endometrium look white in color, white, hyperechoic. This is how you measure the endometrium, from one white line to another white line. This is the myometrium. This is the anterior wall, the fundus, the posterior wall, and the cul-de-sac, and small amount of fluid also seen. So this is known as longitudinal section or the mid-sagittal section of the uterus. When you turn the probe, now you're seeing the transverse section of the uterus, and you can take the measurements for its width. Okay. And again, see the endometrium white in color, and the myometrium, which has got 3 layers, which we'll be discussing. The innermost layer, which is the hypoechoic, or you can say a little darker in comparison to the middle layer, which is more homogeneous and the thickest. And between the middle and the outer layer is the arcuate vessels in between they are coming. So this picture, all of us should learn by heart that how On transvaginal scan, we are able to identify the different parts of the uterus in for better understanding. Now let us see what this clip is going to tell us. Again, see this, how we are seeing the mobility also, and we are seeing the uterus in the mid-sagittal section. We are holding the probe in such a manner with the marker at 12 o'clock position. Now we have turned our probe with an anti-clockwise direction. We can see the uterus coming in the transverse view. On both the sides, we all can appreciate the ovaries coming. See, this was the lady who came to me for the starting of her cycle for an infertility. But on day 2, I could see a large follicular cyst here, which maybe later on will show you. And then we abandoned the cycle for that particular month and put her on OCPs to start with the next cycle. So now we all have clearly understood the different parts of the uterus on transvaginal and transabdominal scan, and see the measurement for length from fundus to the external os. This is the anterior to posterior, and this is from right to left. Okay, so length, breadth, and the depth measurement can be done better on the transvaginal scan. So a word about prepubertal uterus size. Remember this, when the child is born, the uterus, the cervix is bigger than, the cervix is larger than the body here. It's inverted. Like up till now, we've been seeing that the fundus is larger and the cervix is smaller. But in the small babies, it is the opposite. And sometimes where they are born, you find that the endometrium looks white, thick in color. And in fact, 1 or 2 spots of bleeding also sometimes are observed in newborn young. When the girl reaches to a pre-puberty age, how a thin endometrium looks like and how the shape of the uterus also changes. In the beginning, where we are not able to understand the difference between, in fact, the body and the cervix, and then slowly that pear-shaped body of the uterus, they start coming into view. And once she enters into puberty and start having menarche, then normal periods and the growth of endometrium starts. Now, what are the sizes or size of the uterus for a nulliparous or a multiparous? Then we must tell you this thing, that in nulliparous uterus, the dimensions are to be taken from fundus till the external os. So this is between about, you can say 6 to 8.5 centimeters. This is about 4 to 5 centimeters, or maybe about 3 to 4 centimeters, and maximum this is about 4 to 5 centimeters. Same, if you want to have the better understanding of the measurement, then you can also take in the transvaginal scan. For transvaginal scan also, same thing. We measure from fundus till we reaches to an external os. And how to identify external os and internal os, we'll be talking about in the coming few slides. This is anterior to posterior, and this is right to left. So remember this, that for writing the dimensions of the uterus, we always need to have the 3 measurements, the length, breadth, and the depth. And you can take in either way, like maybe a transabdominal or a transvaginal, but definitely the measurements will be better in the transvaginal scan. Again, we are showing you this picture, that how a longitudinal view is seen and how from this fundus till the external os, you take the measurement here, and anterior to posterior is taken from this to this side. Okay. And vagina is not to be included in the measurement of the uterine size. It is only from external os till the fundus. Now for looking into the cervix, how to identify cervix, because that's also a very important part, because you'll be asked to identify where the cervix ends, and maybe if you're looking for, let's say, a cervical cancer, cervical pregnancy, incomplete abortion, anything. So basically what happens is, if you look into this longitudinal section, you are seeing that the vagina is coming like this. Okay, can you all appreciate here? And then this from here, this between the vagina and the cervix, there will be little change in angle. And then between the cervix and the body, there's another change of angle. So if you draw a line from here to here, then this is the area of internal os. And from here, where the vagina is starting, here to here is the external os. So this is the area of the cervix. So this is how it looks in maybe a multiparous, and this is how it looks maybe in a nulliparous. But again, we'll be showing you some more pictures to give you a better understanding how to have the understanding of where the cervix is on transvaginal probe, then what you have to do is little bit take out the probe and look for this fold of the urinary bladder, fold of the urinary bladder. And where this fold is touching, if you draw a line from there to this point, so where this point touches, that is the internal os. And from here, you can see the cervical lip coming here, and this is the area of the cervix. So whenever you are asked to look for cervix, then in transvaginal probe, withdraw your probe, or if you're lucky enough, sometimes you are able to identify these Nabothian follicles. So if you see these Nabothian follicles, then this is the area of the cervix. So there's nothing like, I will say, a measurement of the importance of measurement of the length of cervix. Yes, the importance is the echogenicity, presence of any abnormality, any pathology, any uterine sac, or let's say incomplete abortion. So that is the reason we must know how to identify cervix. Again, see this transvaginal probe, and in multiparous, how this cervical canal is looking like. Can you see this fold coming here? This fold. This is another way of identifying that wherever this fold is pointing to, this will be the area of the internal os. Again, on the transabdominal scan, look for the Nabothian follicles or the Nabothian cyst, and they will also give you a clue that this is the area of the cervix. Now see again, both are transabdominal scan, but one is for nulliparous. So look at the shape. It looks thin here. Can you see this? Anterior to posterior is thin. But once she has given birth, then this looks more globular in shape. Both are normal. And that is the reason the range is always been given for measurement of the dimensions of the uterus. So remember this, you always have to ask her parity, that how many children she's already given birth to, is she nulliparous, because that will also help you to see whether this uterus is looking okay or not. Now, as a gynecologist, very important thing is that we must write down whether this uterus is anteverted or anteflexed and retroverted or retroflexed. Very, very important. Sometimes we are doing a scan and we are not able to, in fact, identify uterus, and we are struggling with, first of all, we must take a history. If there is a history of hysterectomy, so naturally, if uterus is not there, how will you identify? Okay, or if there is any history of any other pelvic surgery for which maybe uterus is in little different, like you can say, position. So we have to ask about the detailed surgical history. Then remember, uterus physiologically is more commonly seen as anteverted and anteflexed. But still, you can say out of 10 patients, at least in 1 or 2, we will also see a retroflexed uterus, but rarely also a retroverted uterus. Now, what is the meaning of these two words and how to identify? Because identifying this position is extremely important for a gynecologist or a sonologist to tell the gynecologist before she's doing any intervention like dilatation or curettage or any other like IUCD insertion or anything. So descriptions of flexion refer to a relationship of the body of uterus to the cervix. And version is the angle between the cervix and the vagina. So how to remember version word V and vagina? That means the cervix is constant. So any angle between the cervix and the vagina is the angle of version, and the angle between the cervix and the body is the angle of flexion. See now, let's say this is the vagina. It is going like this, and then comes the hair, the cervix. So this is the angle between the vagina and the cervix is version. Then as the cervix is now entering towards the body, this angle between the body and the cervix is the angle of flexion. Look at this now. Can you all appreciate this is the urinary bladder and this is the fundus or the body and cervix here. Okay. Now there is an angle formed between the vagina and the cervix, which is the version, and between the cervix and the body, which is the flexion. So whenever you see that this body of the uterus is more towards the urinary bladder, that is anteflexion. And whenever you see that this body is going away from the urinary bladder, that is retroflexion. Now let us see one by one. Can you see the urinary bladder? Okay. And this body of the uterus is towards the urinary bladder. So anteverted, anteflex. This is the vagina. So one angle is between the vagina and the cervix. Okay. Another is between the cervix and the body. So from here to here. So when the body of the uterus is more towards the urinary bladder, this is anteverted, anteflexed. Same for the transvaginal scan. As I told you in the beginning, urinary bladder is on this side. So that means this body of the uterus is going more towards the urinary bladder. So anteverted, anteflexed uterus. See again, look at this picture towards the urinary bladder. But when the urinary bladder is here, but this is going away. So this is retroversion or retroflexed. Retroversion means complete from the vagina itself is going away. But when between the cervix and the body, this angle is more towards the rectum, this is retroflexion. So sometimes there is a confusion between these two, but let us see how we actually see on the scans. So this is how on transvaginal probe, the probe is entering. So now clearly you can see towards the urinary bladder, this is anteverted. Okay, see now on transabdominal scan towards the bladder, anteflexed. See urinary bladder here, fundus is going away, retroflexed. Fundus is going away, retroflexed. But between the vagina and the cervix, the angle is okay. This is anteverted, retroflexed. Anteverted, retroflexed uterus. Okay. So this is very important because if somebody is doing a procedure here, let's say somebody wants to, let's say this is a missed abortion, somebody wants to take away this and do a dilatation and curettage. But if you do not know that this is not anteverted, this is retroflexed uterus, then you can do perforation of the posterior wall. So extremely important for a sonologist to mention the position of the uterus. Now in this picture, if you see the complete vagina, between the vagina and cervix also, the angle is towards the rectum. And then the complete uterus is going away from the urinary bladder. So this is retroverted, retroflexed uterus. Retroverted, retroflexed uterus, which sometimes look like a myoma only because you're not able to identify where the uterus is. For this, transvaginal scan is extremely important because in that, you'll be able to see fundus going away from the uterus. Now in this picture, beautifully you can see this vagina is coming here and between the vagina and the cervix, the angle is okay, right? This is okay, that is acute angle. But here, the fundus is going away from the urinary bladder. This fundus should have gone like this, but it is going away from that. So that is retroflex uterus. I hope I made this understanding very clear. Only thing, if you are confused, you must remember is the fundus close to urinary bladder or it is going away from the urinary bladder? Then at least you will have some clue that whether this is an anteverted, anteflex uterus or a retroflex uterus. On TVS, it's very easy to identify a retroverted or a retroflex uterus. Why? Because this is a TVS scan and in the beginning only, I told you for image orientation that this part is where the urinary bladder is seen. That means on the right side of the screen. Now, the fundus actually should have been, instead of coming like this, it should have been here, but it is coming on this side. This shows that this is a retroverted or maybe a retroflexed uterus. And these are the patients where it is difficult sometimes, in fact, to also identify an early pregnancy and they look like a myoma. So we need to little bit be more careful while identifying. In postmenopausal pelvis, remember the uterus size also becomes a little smaller and the endometrium also becomes very thin. And it is also difficult to identify the ovaries because they do not have any follicles. So this is how a thin endometrium will look like. So whenever you're seeing a postmenopausal patient who's actually is kind of an amenorrheic for let's say a couple of years and suddenly she comes to you with maybe a spotting or a heavy bleeding and you're doing a transvaginal scan for her and you see this kind of a thickened endometrium, it should immediately raise your ears or ring the bell that yes, I must definitely take her for a hysteroscopic fractional curettage to look for endometrial carcinoma, because we all know that in postmenopausal patients, the endometrium is going to be very thin, maybe about less than 5 millimeters. So again, in transvaginal probe, again, I wanted to show you this picture, that how a thin endometrium will look like. And I also wanted to show you this curve, that how if you draw a line from this part till here, so wherever this line is coming, this is the area of internal os. So in postmenopausal ladies, remember this, that we also need to be very careful in identifying that where is the cervix. We have to be very, very careful. So I request that those who are looking for some questions, if they can write down in the chat box, surely I'll answer all the questions. But once this talk is over, because I believe that sometimes when the talk is complete, some of the questions will already be answered in the talk. Now let us begin with how to identify the endometrium and how does it look like. So remember this, there are 3-4 societies in the world. One of them is AIUM, then British Medical Society, then ISWA, who have actually defined how to measure endometrium, myometrium, and different societies are now coming up with standard guidelines to do the measurement. And we must respect what they're saying and have to follow this. So let us understand that how an endometrium is to be analyzed. So endometrium should be analyzed for its thickness. Very, very important. Of course, we have to look for that. Then for focal abnormalities, are there any polyps? Looking their echogenicity, presence of any fluid or masses in the cavity. The thickest part of the endometrium should be measured perpendicular to its longitudinal plane in anterior posterior diameter from one echogenic line to another echogenic line. Very, very important. Remember this. We have to take the measurement of the endometrium in mid-sagittal section, where complete endometrium is visible to us from fundus till cervix. And then we have to measure the thickest portion. The adjacent hypoechoic myometrium and the fluid in the cavity are to be excluded. It should be reported if the endometrium is not absolutely seen. We must write that endometrium was not visible clearly, so endometrium measurement could not be done. Now let us understand how do different endometrium in different phases they look like. So in the menstrual phase, the endometrium appears thin with as a broken hyperechoic line. In the proliferative or mid-cycle, the central part of the endometrium becomes hypoechoic and surrounded by an hyperechoic rim, which is also known as multi-layered appearance. And during secretory phase, the endometrium looks totally hyperechoic and thickened. And their measurement is somewhere between 1 to 4 millimeters in the menstrual phase, 4 to 8 proliferative, and the secretory phase, 7 to 14. And we all know postmenopausal, in case she is asymptomatic, till 8 mm, we do not touch the patient unless she has some symptoms. Now, this is how on transvaginal scan, the endometrium looks like. And as I told you, from the cervix, we have to keep seeing the endometrium. We have to identify the thickest portion and take the measurement from one white line to another white line in the mid-sagittal section. In the mid-sagittal section, so extremely important. See this transvaginal scan, mid-sagittal section of the uterus, triple line endometrium, and from one white line to another white line, we have to do the measurement. You all can see menstrual phase, thin endometrium. In fact, without measuring only, I can say this is about maybe 2 millimeters. Let's say there is some fluid in the endometrial cavity. Then we are not supposed to measure the fluid. We will be measuring only this portion of the endometrium, this portion of the endometrium, add them together. Or second thing is, take the measurement from here to here and subtract this part. Then this will give you the endometrial thickness for that person in that particular day of her menstrual cycle. So how to measure endometrium? We all have understood thickest portion, mid-sagittal section, we have to take the measurement, thickest portion, not hair. We have to take hair to hair. Thickest portion of the endometrium is to be taken. This is the proliferative phase. We all can see how a triple N endometrium is seen, and see how in the secretory phase we can see white hyperechoic thickened endometrium, and we all have understood that how the measurement is to be done. By this picture, you can compare now how in the menstrual phase, when the endometrium has shed, it will look like. As under the influence of estrogen, it starts growing, proliferative phase. Under the effect of progesterone, when there is a large amount of secretions, it looks white, hyperechoic, thickened endometrium, and this is the secretory phase. Hope I am clear in explaining how endometrium is to be measured and how it is going to look in the different phases of the menstruation. Now comes the myometrium. So myometrium has got 3 layers, and the innermost layer is the compact and hypovascular, which is hypoechoic. It is next to the echogenic endometrium. Okay. The intermediate layer is the thickest, which has got uniformly homogeneous echotexture, and the outer layer is again less echogenic. Now let us see this picture. Zoom picture of a transvaginal section, transvaginal probe, showing a mid-status section of the uterus with this white hyperechoic endometrium. This is the innermost layer of the myometrium, which is thin, which is little darker. Then comes the intermediate layer, which is more homogeneous and thickest. Then comes the arcuate vessels, and outer to this is the outermost layer of the myometrium. Now, again and again, why I'm showing you all these pictures? Because I want you all to understand how a normal endometrium and the myometrium looks like. So in case you're finding here some myoma or adenomyosis, and the echogenicity is not looking like this, you must have suspicion in mind. There is something which I'm not able to identify, but this is not normal. Because remember this, whenever we start doing an ultrasound, there'll be about 70 to 80% of ultrasound scans where we're going to see a normal uterus with normal endometrium for that particular phase of menstruation and the myometrium. And then if you know how a normal looks like, then surely you'll be able to pick up the pathology. So this is again a beautiful zoom picture of showing us how to measure the endometrium. See this? Can you see this? Subendometrial halo. Very, very important. Again and again in my next classes on infertility and in the endometrial carcinoma, I'll be talking about this layer. So today I want all you to know that this is the innermost layer of myometrium, and this is also known as subendometrial halo, and it's extremely important to learn this finding of seeing the 3 layers of the myometrium to understand the myometrial pathologies, which is going to be our next class. Now for ovaries. Ovaries are little mobile, 2 in number, in right and left adnexa, and you can only recognize them well because of the presence of the anechoic follicles in them, right? Follicles. So they look like ovoid structures, like an hen's egg. We have to take the 2 angles, that is the longitudinal section, and then turn our probe 90 degrees to look at how they look in the transverse section, and take the 3 measurements to take the volume, and how a normal volume for a normal ovary in, let's say, a proliferative phase or the menstrual phase, the normal anatomy cell. And I'll be very happy to answer all your questions, but let us complete the talk because most probably all your questions will be answered while my talk is going to be over. So as I told you that for every organ that we are measuring, we need to know the normal diameter, volume, and how the echotexture of that particular organ is going to be. So the normal length for a normal ovary in reproductive age group in proliferative phase. Remember, ovary, the volume and the dimensions will change as per the cycle, menstrual cycle. Because if you're looking at the ovary in a menstrual phase, and if I want to tell you, okay, tell me what is the antral count for this lady. So how do you count antral count? You will start counting these follicles. These are follicles, 1, 2, 3, 4, 5, 6, 7 in one ovary. And On the other side, in the same ovary, in the other section, 8, 9, 10, 11, 12. So already there you can say 12 enter follicle count. So you can say, oh, it's a very good count. And in case we are doing an induction, let's say with a clomiphene, we're going to have a very good result. But then in the infertility class, we're going to discuss that how to label these ovaries as either a normal ovary or as a polycystic or an ovary where we require gonadotropins for induction. So those who haven't attended our Doppler physics class or grayscale physics class, maybe they will not have an understanding about the RI or the peak systolic velocity. But we're going to repeat our class again and again, and you can join them and maybe have a better understanding. But for understanding of how to identify ovary, that is with the help of the follicles, because the follicles, they look anechoic, cyst-like structures which are present in the background of an hypoechoic stroma. Now see again, longitudinal and a transverse section of an ovary. So with the follicle only, you are able to identify ovary well. So imagine when a lady has entered into a menopause, when there are no follicles, so ovaries are very difficult to diagnose. Then you have to maybe use an ovarian ligament or use your tags to identify where the ovary is. But in the reproductive age group, very beautifully with the help of these anechoic follicles, we can identify where the ovary is. And of course, we'll be talking about later that how to diagnose polycystic ovaries later, or in the, you can say a menopausal lady where no follicles seen. In fact, I was not able to identify where the ovaries are. I was struggling, and this is, I think, one of the very newer this thing. Recently, we saw this, and she just an age group of, let's say, 37, 38, but premature menopause, and the volume was coming out to be only 1 cubic centimeter. And normally it's about 6 to 8 centimeter is the normal volume for normal ovaries to be in the reproductive age group. Now, suddenly, if a lady has come to you for, let's say, induction on day 2, so in that ovary, if you see this kind of a follicular structure, so that becomes a follicular cyst. So we'll be discussing in our next classes, not today, that actually what are the follicular cysts, how to diagnose whether these are hemorrhagic cysts or are these a kind of a hyperstimulation syndrome, are these dermoid or multiple large follicles seen. So why I am just showing you these pictures is that this is how a normal ovary will look like. So with the help of follicles only, we can identify the ovary, okay? But these pictures will give you some idea, okay, these are also normal ovaries with some cystic structures which maybe are physiological. And in our next classes, maybe we'll be discussing that if you see this kind of a structure, which is an hemorrhagic cyst, could be a corpus luteum hemorrhagic cyst, but as soon as the periods come, this cyst disappears. And how we could have, written this as some kind of a cancer, but that actually is not a carcinoma, and it's simply an hemorrhagic cyst, which is going to disappear once the period starts. So these pictures, which actually give you some idea that how benign ovarian cyst, and this is a typical picture of a dermoid where you see a cotton wool-like appearance. And this again we'll be discussing in our next classes. Now I'll be showing you certain videos to look into it. Now, see this picture. Can you all identify where an ovary with a large 2 big follicles seen in the right adnexa? Okay. So nicely, if I'm telling you this is a TVS scan, and I'm using now Zoom to identify that here the uterus is, because I was trying to look for the right ovary. So this is how 2 follicles, large follicle on day 12 and 13, they will look like a dominant follicle. And then you can take, let's say, the measurement and also look into the endometrium. And as I told you, that you will see a triple line endometrium whenever you see a dominant follicle. So these two also should match in case somebody is doing a lot of infertility practice. Then how to measure the follicle? That means from inner to inner, you have to take 2 dimensions, take a mean. So take at right angles and take the mean, and then see what is the size of the follicle. So in the next classes, maybe we will be discussing that what do you mean by size and how it is going to be useful. Again, see this. Now we are looking into the left adnexa, because we have focused you can say a transverse section of the uterus in transvaginal scan. And I'm trying to show you that how after a dominant follicle ruptures, this is how a corpus luteum, a dominant follicle, which in the earlier scan or earlier picture I showed you, that becomes this kind of a picture when it becomes a corpus luteum scan, corpus luteum. And if you're using color Doppler, because today we are short of time and we will not go into the details of the color Doppler, but color Doppler you can use for identifying the corpus luteum in case you're not able to identify where that follicle has gone and you're thinking, oh, I was able to see a large follicle here. Where is that? I'm not able to see anything. But if you use color Doppler or power Doppler, you'll be able to see a collapsed follicle with some flow around. And this is how a diagnostic feature of corpus luteum it looks like. Now see this. If I ask you now, since you all have understood very well, and in fact you all have same understanding what I have. If I'm showing you a urinary bladder here on this side and I'm holding the probe correctly, what is the position or the orientation of the uterus? So I think all of you can answer and say, yes, this is a retroflex uterus going away from the bladder. Can you all see going away from the urinary bladder? And this was a case of a very early pregnancy. In fact, I was not able to identify a small sac, which later on, after doing it 2-3 times, I was able to identify a small sac here. Maybe in some next pictures, I'll be able to show you. So let's again see now that how the dimension of the cervix, as I told you, the angle between the vagina and the cervix here. So this is the external os, internal os, and this is how you take the measurements of the uterus, the longitudinal and the transverse sections. We all have understood this is how you look into the right and the left adnexa, look for the ovary size, and with the help of an ovarian ligament, we are able to identify where the ovaries are. Now let us see this transabdominal scan and look for how to identify ovaries. I am simply sliding my probe and moving from right to left. And with the help of an ovarian ligament, I am able to identify where the ovaries are. And ovaries, as I told you in the beginning, can only be identified with the help of follicles. Can you all see? I'm using again zoom to show you that how on transverse section, we can see the transverse section of the uterus. And now I'm going from right to left and see this follicle coming into view, an ovarian ligament. And on both the sides, I can see the ovaries and the uterus in the transverse section. So I think all of us now have understood very well that how to identify the uterus and the ovaries. So this is a very, very interesting case. This position of the uterus is known as axial position. This is not retroverted, retroflexed. Neither is this anteverted, anteflexed. This is coming in between. That means the vagina, the cervix, and the uterus almost comes in a straight line. This is how, and this position is known as axial position. And rarely you see this kind of a uterine position also. See, again, see this. I'm trying to show you how ovaries and how the uterus in this axial position was seen. And it was difficult to see how, can you see the straight line coming from the cervix to the fundus? And then on, with the help of this mid-status section only, I'm trying to identify where the ovaries are. And I was focusing the right ovary. Again, see this, that how I'm looking for the right ovary. And also one thing I want to show you in this video, see now, right ovary is coming into view and beautifully you can see the right ovarian ligament. And also, can you identify that transvaginal scan beautifully is able to also tell you that how the bladder movements, the movements in the bowel takes place. And it's easy to identify, differentiate between the ovary and the bowel loops where you can see the food particle moving here and there. So this axial position of uterus is also extremely important, and sometimes on transabdominal scan, you're not able to identify the endometrium very nicely, and we have to go for a transvaginal scan to identify this. Again, see this. See again, I am always holding probe correctly. So no matter what is the difficult situation I fall into, I keep the urinary bladder on one side, that is the right side. This was the right ovary, and see again, uterus is almost turning away. That was a case of a retroverted retroflex. I was not able to focus uterus while I was trying to look for the ovaries because this was so much tilted away from the urinary bladder. So what I wanted all of you to learn from today's class is that try to use this transvaginal probe correctly And I'm sure that your diagnostic skills will improve like anything. You'll be able to identify ovaries so well with the help of this ovarian ligament. Can you see this ovarian ligament? If you just follow the uterus from the transverse section and just follow where the ovarian ligament is, you will never be able to miss the ovary. You will never be able to miss the ovary. So all these videos I want to show you. See again, uterus away from the urinary bladder. Again, see this. And the left ovary is coming on that side. So why I want to show you this thing, that if you're holding the probe correctly, the urinary bladder is on this side and the fundus is going on that side, that means that is a case of a retroverted or a retroflexed uterus, and it's sometimes also difficult to identify a pregnancy in that case. See again this picture. This is a trans-abdominal scan. Now I won't tell you the answer. You tell me what all can you see in this. Nicely we can see a IUCD here, which is there in the lower uterine segment. This is a retroflex uterus. So maybe while inserting IUCD, the doctor couldn't put it right inside because of the position, and see, this lady came to me with an early pregnancy. And I will show you this. If you see this here, the small uterine sac is also available, is also seen. Again, see this picture. Can you all see an IUCD, shadow, and an early pregnancy here? IUCD with a shadow and an early pregnancy here in the retroflexed uterus. Beautiful picture, a video, a very nice picture where we all can see this. Again, see this still picture. Can you all see this? Full bladder and the fundus is going away. Instead of this, fundus should have gone like that. It is going away. And this early pregnancy, we would have definitely missed in case we would not have been careful by looking at IUCD in the lower segment. I thought, no, I should not miss anything. And I saw it again and again, and I was able to identify. Can you all see this early pregnancy? Beautiful picture of an early pregnancy in the retroflexed uterus. Now see this picture of an IUCD. Okay, IUCD. Can you see this? How in the transverse section an IUCD is seen. This is a longitudinal section, how an IUCD is seen, and why I wanted to show you this, because this is the area of internal os. So if you ask me, what is the correct location of IUCD? When it is above this internal os. But in case this IUCD would have been here, then I would have said, no, it is in the low lying position. This is how you see IUCD in the transverse picture, a cut section, and you can see a shadow also. Can you see nicely, all of you, an IUCD, white hyperechoic? Okay, so this is not endometrium. When you see more white looking thing, that means this. So in 3D, if you have a 3D, nicely you can see IUCD in the correct picture. So since this is not a 3D class, so we are not discussing much at this time, but you can see that now how a low-lying IUCD will not actually prevent the pregnancy. And before I end my class, I will also tell you that in case the IUCD is low-lying, how sometimes the pregnancy happens and we can miss on that. Now let us see what happens. See this very beautiful picture. Can you all see early pregnancy with an embryo, and IUCD is seen in the lower uterine segment. See this video. Can you all see embryo with an IUCD in the lower uterine segment? Use always zoom. So zoom will also give you an idea. Here IUCD is seen and we can see an embryo here. Can you all appreciate this? Okay, so now we all have understood that how a low-lying IUCD is seen. And this one more picture I wanted to show you, that the importance of seeing the transverse section of the uterus in the transvaginal set. Whenever you see that this is looking more broad, and when you're going up in the uterus, you see two endometrial cavities. This can be a screening for a congenital anomaly. See now. You yourself will see and tell me that how on transverse section we can see that the transverse section of the uterus is looking much more broader, and you will see two endometrial cavities on each side. Two endometrial cavities on each side. Okay, so this is a screening method. You can say 2D is a screening method to rule out, and this was a case of a septate uterus. A septate uterus when we checked with the help of a 3D picture, which of course at present I'm not able to show you. And this zoom picture, which is my last video, which I want to show you how the cervical lip will be seen here. And you all can, I think, see the Nabothian follicles. Can you see this fold? So this picture, I want to tell you that if you draw a line from here to here, you will reach internal os, and how an external os is seen here. And this also helps in ruling out, you can say, look at the mobility. So you all will be able to rule out, in fact, deep interstitial endometriosis. So you all can see nicely the mobility, and there was no evidence of any pain because as such, the uterus, the cervix, everything looks absolutely clear in this lady. So I want to show you that how a cervix with two lips will be seen and how an internal os and external os. Can you all able to appreciate here how the cervix is being seen, because I'm withdrawing the probe outside and now I'm using zoom as well as decreasing the depth so that you all can appreciate beautifully that how a mid-sagittal section of the uterus along with the endometrium. Also